in the healthcare system makes from keeping people in the system. So a huge system has been built around people who are sick, and there is a lot of money made in the entire system. It's not just the insurance companies, it's the entire system. There's jobs, there's everything, right? People say it's sick care, so there's a lot more money made in sick care and jobs and all that stuff by people being sick than preventing people from getting sick in the first place.
Welcome to In Good Company.
Okay, well, yeah, I'm Dr. Marc Pietropaoli. I am a sports medicine fellowship trained orthopedic surgeon and regenerative medicine specialist. So what does all that mean? Well, it means I take care of, bones and joints and cartilage and tendons and ligaments and muscles. And I am trained as a surgeon, sports medicine trained under Dr. James Andrews, who's the greatest sports medicine doctor of all time. I am biased, but he is. And so I do still perform little minimally invasive surgeries. A lot of what I'm going to talk about, or what I talk about in my book, Repair Not Replace, is stuff that I wasn't taught or I didn't even really believe, because the way the system trains you, it trains you that, if you want to be an orthopedic surgeon, then you do surgery. And, if someone has arthritis in their knee, then and they don't get better, you put metal, plastic, and cement in there. You put a knee replacement in there, but I always liked Star Trek. I always liked Bones McCoy with the tricorder, where you could diagnose and you could kind of treat somebody with this thing that was non-invasive, even though I'm a surgeon and I do go inside of people's bodies to fix it. But I always thought that was a really cool thing. And now we have ultrasound, so we can look inside people. We have laser, we can treat people with laser, ultrasound, other things. So we're getting closer to the tricorder, but I just always had that mindset. But I knew I wanted to be a sports medicine doctor, and my uncle, who was the original Dr. Pietropaoli, he said, if you want to be a sports medicine doctor, you have to be an orthopedic surgeon. So I was like, all right, I'll be an orthopedic surgeon. So it was my third year of medical school. It was 1991. I'm in Syracuse, New York, going to school, and I found out that I was going to be watching Dr. David Murray, who is one of the original inventors of knee replacement surgery, perform a knee replacement on my first day of orthopedics. So I was really psyched. Get there early. The junior resident's like, well, you're a medical student, you're not going to scrub in, but just kind of stand over in the corner, don't touch anything. So I stand over in the corner, I don't touch anything. The patient comes in the room, the nurses transfer the patient to the OR table, and the anesthesiologist puts the patient to sleep. Dr. Murray walks in, very tall, stately man with glasses on, very professional man. And the chief resident, who's in his last year of training, is about to go out the next year into practice. He's going to take him through the surgery. So they get the patient all prepped and draped. And then Dr. Murray says, knife, and then they hand it to the chief resident, and they start the surgery. And next thing I know, there's this huge incision, about this big. You can't really see it it's bigger than the screen. And there was saws and drills and hammers, and it was just really loud. And at first I was really excited. I'm like, wow, I get to use power tools to fix people. Like my dad taught me how to use power tools. This is going to be great. But as I watched and I saw how big that incision was, and I saw cartilage and bone and blood flying all over the place, I was like, it's a little gross, and actually it's a little barbaric. Because there's got to be some better way to like fix a knee or grow back cartilage. And so I remembered what the junior resident said. He had said to me, he said, don't touch anything, but feel free to ask any questions, because there's no such thing as a dumb question. So I got the courage up and I raised my hand up, and he looked at me like, oh, this guy's actually going to ask a question, but he didn't acknowledge me. And the chief resident kind of glared at me, and the nurses glared at me, and the anesthesiologist, eyes open wide. And then just complete silence. No one said a thing. So I was about to put my hand down, and Dr. Murray looks over his glasses and he's like, oh, Mark, you have a question? I was like, yes, Dr. Murray. First of all, thank you for letting me be here. It's amazing. I really appreciate it. But my question is there any way to cure arthritis? Is there any way to grow back cartilage? Is there any way to repair a knee and not replace it? And before Dr. Murray can even get a word in, the chief resident points at him. He's like, no, there's no way to cure arthritis. There's no way to grow back new cartilage. There's no way to repair a knee and not replace it. So at that moment, I was very embarrassed. And I realized, there is such thing as a dumb question. But I also had a light bulb go off in my head. And I said, I'm going to prove that guy wrong someday. Someday I'm going to figure out how to repair knees and not replace them. And that's kind of where knee repair, not knee replacement comes from. And now 35 years later, I've written a book, Repair Not Replace. So that's kind of my very short version of how I've got to where I am and why. I mean, there's other stories in the book that go into more detail, but that's kind of the 2 or 3 minute version.
So walk us through some of the research that you've done with your book and how you came to this conclusion.
It's called Repair Not Replace because our bodies have an amazing ability to repair ourselves. That's where the regenerative medicine part of it comes in. And so if we didn't have this amazing ability to repair ourselves and heal ourselves every day, we would fall apart. Now, as we get older, that healing and that regenerative properties and it doesn't work as well as it used to, but it still works pretty good. And there's still a lot of healing cells inside our body, healing growth factors. So most people have heard of stem cells, and stem cells are cells that haven't turned into anything yet. They can turn into, cartilage, bone, kidney, liver, lung, whatever, in the right circumstances. And our bodies have stem cells throughout our entire bodies, all throughout the whole body. And each organ has their own kind of special stem cells. But there's also some really generic stem cells, and especially in our bone marrow. And those cells are most prominent in our bone marrow. We have a lot of them in our fat. But as we get older, we have less of these stem cells, these repair cells in our extremities, our arms and our legs. And I'm an orthopedic surgeon, so I deal with a lot of extremity problems. And so our bodies start to break down a little faster than they can repair themselves. And we start to break down, and the cartilage on the end of the bone starts to break down. And then the bone underneath the cartilage starts to break down, and you get these little soft spots in the bone, and they're stress or microfractures. And the cartilage on the end of the bone that looks kind of like the white on the end of a chicken bone, is kind of like the tread on a tire. When that wears down, that's what arthritis is. But that doesn't have any nerve fibers in it, so that doesn't really give people a pain. The pain comes from the bone getting soft underneath. And, I will give credit where credit's due. Dr. Hernigo is a French orthopedic surgeon who, back in the late 1990s, you asked about research. When people say, oh, there's no, the knee-jerk reaction is, oh, this is new regenerative medicine, or there's no research on it. I mean, that's all not true. It's just that we're not taught that in medical school or in our residency programs. Maybe it's starting to catch up nowadays, but we're really not taught that. So the knee-jerk reaction, if you don't know, is, well, there's no research, or it's new, it's experimental, and all that's not true. And so Dr. Hernigo, French orthopedic surgeon back in the late 1990s, early 2000s, so a while ago, he had 140 patients who had arthritis in both knees, severe enough that they were told they needed knee replacements. And so he said, I'm going to do a knee replacement on one of the knees, and I'm going to do stem cells on the other knee. I'm going to take good bone marrow from your pelvis. And as we get older, our arms and our legs don't have as good of a bone marrow, as many cells, but our pelvis, even into our 60s, 70s, and 80s, still has good stem cells. And it's right underneath. It's above the buttock area. It's under the skin. It's pretty easy to harvest. And so he took good bone marrow, concentrated it, and he injected that into the one knee where those soft spots were, into the bone, try to get them to heal. And the other knee, he did a knee replacement. And then he followed these people for 10 years. I mean, most studies only follow people for a year or two. So 10 years is amazing. And by the time the study was over, some people had been followed for 15 or 20 years. So the average follow-up was actually 15 years. So at the end of the study, after 15 years follow-up, 82% of the knees who just got the little poke holes, not the big saw in the bone and the cartilage and all that stuff flying around, 82% of those knees never needed a knee replacement. And and they felt that knee felt more normal than their knee replacement knee. And not only that, 15% of the knees that got the knee replacement needed another knee replacement, a revision, which is a much harder surgery, doesn't last as long, more risky. So there's a lot of research out there. Repairing the bone is definitely something that we can do. And there's a lot of other things we do, but that's just some of what I utilize to help your body heal yourself.
Could you walk us through some of those recommendations on what people can do, like the first steps?
Well, the first step, I think the other problem with the current medical system is that a lot of what gets done is the doctors don't have time, right? They have maybe 10 minutes to spend with the patient. There's no way you can even get their history, do a full physical exam, review all their imaging, get the appropriate imaging, x-rays, MRIs, whatever is needed, and then actually interview them, find out what their goals are, what their dreams are, because everybody, depending, if you want to just walk up and down the stairs without pain and sleep through the night without pain, that's different than someone who wants to play pickleball, which is different than someone who wants to hike, which is different than someone who wants to travel the world, play with their grandkids, run marathons, right? Everybody has different goals. And, in 10 minutes, you don't have time to do all that stuff. So what happens is we're trained to get people through quick, and we're trained to just treat the symptom. Okay, you have knee pain. We don't really care what the underlying cause is, or maybe we'll just say, quote, you have arthritis, some nebulous word that most people don't understand what it means. They just know it's something bad, and say, here's some pills, or here's a cortisone shot, see you later, or here's some gel injections, or or maybe even let's just do surgery right off the bat. And that's kind of how the system is. And I was in that system for 25 years, and it's a very difficult system to be in. And it's not really doctors or physical therapists or healthcare providers' fault. That's the way the system is, and it's hard to get out of that system. Most doctors do not want to spend only 10 minutes with a patient. They don't. It'd be rushed through 6 patients an hour, 60 patients in a day. It's not fun. So with that system, it's very hard to get to the root cause of what's going on. So for me, time is the secret sauce. Spending enough time with somebody, you can really figure out what's wrong with them. Yes, getting the appropriate studies, x-rays, MRIs, ultrasound. I love ultrasound. You can look inside somebody. It's like a second set of eyes. Those are all extremely important. And even like for physical therapists, for instance, they often only get 20 minutes with a patient, and they might have, quote, knee pain, but they might have a back issue that's causing their knee pain, or their hip is tight, or their ankle's tight, and they don't have time to take care of all that. They just focus on the knee when that's not really the underlying overall problem. Maybe you make it feel better, but if all those other things aren't corrected, it's just going to go back to where it was again. So we spend a lot of time. We do a thing called the Clarity Day, which is in the book. I think it's chapter 5, and we go through all of what we do, but we'll spend 4 or 5 hours with somebody in one day, and we'll do everything I said there. We'll get it all done in one day instead of going from appointment to appointment and insurance authorization, all that cycle of insanity that sometimes takes patients, 3 to 6 months or even longer just to get through, to figure out kind of what's wrong. We figure out what the root cause is, and then you can decide, are you a candidate? How can we treat it? Do we have to refer you on? Are you a good person for what we do? So I think figuring out what's wrong first would be my first piece of advice.
How much of the insurance industry has driven healthcare to act in the way that it does? Because oftentimes I've often been curious, it's like, well, what if they, paid more for more time during diagnosis, just like you just described? Because, when you go to, some of the most renowned, like the Mayo Clinic, Cleveland Clinic, though typically you're not just talking to one person, you're talking to a team that's working together on the same patient at the same time. Whereas for most people, it's very segmented. You're being carved up into pieces, and so there's no, I don't want to say no collaboration, but it seems more limited in our system. And so it's like trying to figure out why the system is set up the way it is. And I'm assuming it's the way the insurance company sets things up, but it's probably more than that.
It's definitely more than that, but that is a big reason. I mean, the insurance companies, we'll go down this rabbit hole, I guess, but a lot of insurance companies own pharmacies. A lot of pharmacies own insurance companies. There's middlemen in between as well, pharmacy benefit managers. There's a lot of stuff you can look into with regard to that. But just in general, our system is a reactive system. It's not a proactive system. No one's going to disagree with that, not even the insurance companies. And they in some ways, they have tried to get a little bit more proactive, because it would save money in the long run to be proactive. And yes, they should pay more for preventive and proactive things. And here's a surgeon saying that, like, because obviously surgeons get paid more to do surgery, but even that is tiny compared to what the insurance companies make from keeping, and the healthcare system makes from keeping people in the system. So a huge system has been built around people who are sick, and there is a lot of money made in the entire system. It's not just the insurance companies, it's the entire system. There's jobs, there's everything, right? And people say it's sick care. So there's a lot more money made in sick care and jobs and all that stuff by people being sick than preventing people from getting sick in the first place. Also, the insurance companies do make a fair amount of money with these pharmacy benefit managers. and or the pharmacies make a lot of money. Obviously, the big pharma makes a lot of money with people being on medications, treating the symptom with a medication, but not treating the underlying cause. And that's where there's a lot of functional medicine doctors and regenerative medicine specialists who we try to get more to the underlying cause and treat that. And then people don't have to be on medications and things like that. And I mean, a lot of it still comes down to diet and exercise. There's fancy ways to diet to give, figure out someone's best diet based on their genetics and their epigenetics and how their genes are expressed and everything. And there's advanced ways to train somebody, train their mechanics in their body and all those things. But it's still, a lot of it still comes down to lifestyle, diet, and exercise. And that's not stressed enough in society either. So it's a huge system that's been set up the way it's been set up, and people are conditioned to it, and they're conditioned to treat people after the fact. It's very segmented. I'm only going to see you for your knee. That's all I can see you for. Or if you're a physical therapist, well, I have knee pain and both knees and my shoulder. Well, then the therapist often will say, pick one, because they don't have time and the insurance will only pay for one. And it's not your guy's fault. My daughter's a PT. I've had PT in my practice since 2006. I love physical therapists, athletic trainers. We have a team approach like you described with the Mayo Clinic, et cetera. And the only way to beat the system is actually get outside the system and form a new system. You can't beat the system. And that's what a lot of regenerative medicine doctors, functional medicine doctors have done, is just, you can't beat the system by staying in it. You have to get out of it and just kind of create a new system and let people choose what they want to do. And more people, and frankly, I have kids in their 20s. I'm pretty impressed by how health conscious younger people are nowadays. They're not always the best informed, but they're a lot more health conscious than we ever were at that age. And some of it's good information that they get, some of it's not, but they definitely seem in general to be more informed and more concerned about their health and more willing to do other things. And then you have the people who are retired. They spent all their money. I mean, they saved up all their money. Their kids are through school and they want to enjoy the money they saved up. Now their knee hurts or their shoulder hurts. They can't travel. They can't do all the things they want to do in retirement. They're more interested in their health as well. It's all the people in between who are just busy as heck, who can't take the time, who are trapped in this system.
Why do you think so many Americans at a younger age are struggling with joint pain than previous generations?
Well, I think we are. I mean, the data shows that we are, especially Americans, we're much more obese society. So for every pound of weight you gain, that is 3 or 4 pounds more force going across your joint. As much as I just complimented a lot of the younger generation, there's still too many who are out of shape, who aren't strong enough, who don't get the physical exercise they used to, or if they are, they're concentrating only on one sport versus multitude of sports. So they're using one set of muscles all the time, all year round, and they're getting injured, more. So you can be in great shape, et cetera, but you're only concentrating on one sport, and that makes you more prone to injury. Or you can be kind of just someone who's a couch potato and you don't have enough muscle mass and you gain weight, and that both of those can lead to joint problems and aches and pains. And so being too extreme one way or the other can be a problem. So I think both of those, from a sports medicine standpoint, definitely over specialization too early is a huge cause of joint pain and injuries. And the ACL tears, the main ligament inside the knee that prevents it from giving out when you cut and pivot, that's a huge epidemic. Women, 5 to 10 times more common than men. That's a whole separate podcast, but that leads to arthritis. And so there's simple programs called, like one of them is called Sports Metrics. It was developed at Cincinnati Sports Medicine by Dr. Noyes. There's a whole bunch of other ones now, but that has been scientifically proven to cut the risk of serious knee injury by 50 to 75%. And it's a 6-week program, but a lot of people don't want to be proactive. And then you tear your ACL, all that money that the parents spent on 3 different leagues, all the equipment, the best coaches, the best training, it's down the tubes. They don't want to spend the money on the preventive part. And, when you tear that ACL, you got about a 50% chance of getting arthritis within 4 or 5 years.
Wow.
If you undergo the traditional ACL reconstruction where we make a new ligament, we take your patellar tendon or your hamstring tendon or your quad tendon or even a donated tendon from a donor. those people still get arthritis. They got a 50% chance of arthritis. It just pushes it out 14, 15 more years. And if you're a 14-year-old girl, 14 plus 14 is 28. You're pretty young to get arthritis or have that high of a risk of arthritis. So that's where this bear surgery, I don't know if you guys have heard of it, being a physical therapist, bridge enhanced ACL restoration or repair. So traditionally, making a new ligament reconstruction stabilizes the knee, but it doesn't prevent arthritis. The bear surgery, we're able to sew the ACL back together with a collagen implant in between it. Dr. Martha Murray came up with this at Boston Children's, and I wasn't involved in the research studies. I tried to get into those, and she said, no, I'll call you. You know, those are all filled, but when it comes out on the market, I'll call you. And she did, and I was able to do the first one in the US back in 2021. And one of the ideas with repairing that ACL is you keep your own parts, your own cells, your own nerves, your proprioceptive nerves, your position sense nerves, your own cells, your own blood vessels. And so in the animal studies, significantly less risk of arthritis. Well, now the FDA's come out, and because of the studies in humans, the FDA has a statement that bear surgery, bridge enhanced ACL restoration, has a significantly less risk of post-traumatic arthritis than hamstring ACL reconstruction. So preventing arthritis, preventing the need for knee replacements, all these things, proactive, preventive, they all play into it. So regenerative medicine, those people are kind of already too far along. It'd be nice to prevent them from even getting to that point in the first place. And that's where these preventive programs, diet, exercise, having enough muscle mass, not over specializing, and not being overweight.
That makes sense.
When you say diet, what's specifically do you kind of lean towards?
Over the years, I've had several different staff members. I have my own personal preferences as well. And of course, being Italian, I like the Mediterranean diet the best, right? And it's shown to have longevity, but what does that exactly mean as well? Yeah, it's more plants, and not as much protein, or meats and things like that. You can still get obviously protein from plants, but more of a plant-based diet. That's kind of my preference, but that doesn't really, how do I know that without testing my genetics? So this is a great question, because over the years I've had staff members, some of them are like, you need to be vegan, or you need to be carnivore, or you need to be Atkins, or they all have their own thing. And all those diets can work to help people lose weight, and some of them to even be much healthier. But once I found the genetic-based diet, I thought that was a lot better, because what we do is we'll do a simple mouth swab. It'll go to a lab, and there'll be a 32-page report, and it will come back with what the best ratio of carbohydrates to fats to protein, micronutrients, vitamins, minerals, sensitivities, etc. Now, having said that, that's your genetics, that's your propensity, but you don't always express everything in your genetics. So it does take interpreting what is on the genetic report to what we actually would recommend, or what our health coach would recommend. So it's not as simple as you just like we had a lady, she just recently, her husband went through the program. She just wanted the report and just wanted to interpret it and do it on her own. That isn't the greatest thing in the world. A lot of people get these genetic reports. You can just do a diet test, but what it shows isn't always exactly what you're expressing or what's best for your specific current medical condition. So it's a piece of the puzzle. But once you figure out someone's genetics, it really helps fine tune what the best diet is for them. So that's how I would answer that question. I think your genetics, and then how you're expressing your genetics, your epigenetics, and then all the other factors make a huge impact on what the best diet is for somebody.
Hey, thank you so much for watching this episode of the In Good Company podcast. Make sure you like and subscribe. It truly goes a long way to growing our channel. And also share this episode with someone who needs to hear it most. Now back to the show.
In your profession, you run into inflammation a lot, I'm assuming. And, sometimes I've often wondered as a physical therapist, what started first, the injury and then inflammation came later, or was there something else that caused inflammation to begin with? and how much, that's why the diet question came up, was how much of a role does people's lifestyle play in inflammation in their joints?
A lot. So that's a great question. And sometimes the chicken and the egg are reversed. Sometimes it is the overall person first, and then that starts affecting their joints. Other times it's a joint that maybe got injured or whatever, and then, and then it maybe became chronic and didn't heal the right way, and you get chronic inflammation, and then that leads to other things. Most of the time it's a little bit of both, though. I mean, and that's what we do concentrate on all those areas. We concentrate on the actual area where the inflammation and the pain are, but we also concentrate on the overall inflammation in the body. So part of that genetic diet is to get you on the best diet of real foods. You go to the grocery store, you go to a restaurant, you order the foods that are not going to cause increased inflammation in your body. And that helps. Even if you have a bad knee, it's, if your whole body's inflamed, that's only going to make it worse. So we do treat all those things. We kind of call we call it preparing the fields. I'm a gardener, as I was telling you guys about earlier, and in order to plant the seeds, you really you can't expect to just throw seeds on the ground and have a bunch of weeds there and bad soil. And I mean, maybe a few will grow and you might get some tomatoes come October, but you really need to prepare the fields first. So getting rid of the weeds first. Inflammation chokes out your good cells. It's bad cells, it's bad factors in your body, and it's kind of like weeds. So you want to get rid of the weeds, you want to get rid of the inflammation. Then you want the right topsoil. And so that's kind of your diet that has the best nutrients for you. And so we try to do that first, and we use a combination of that genetic diet. We also use a red light laser, which does help get rid of fat. Now, fat causes inflammation, and fat is stored in fat cells. Fat cells are okay. We're okay with them. We just don't want too much fat being stored because that causes inflammation and weight. So there's certain wavelengths of red light laser that cause the pores on the fat cells to open up, and the fat drains into your lymphatics, and you eliminate it naturally. And even after one treatment, people can lose 3.5, 3 3/4 inches of fat when we measure them across 3 or 4 areas.
Wow.
Now, if they go home and drink beer and eat Twinkies, they're going to fill those fat cells right back up. That's where the diet comes in. So the red light laser is more like a weed eater or a jump start, whereas the diet is more like the topsoil. And then once you have the topsoil and you have the weeds out of there, now you can plant the seeds. That's where I come in, or my PA, where we harvest your stem cells, which seeds are cells that when you plant them in the garden. Well, we take your cells and we transplant them into the spot that we want to heal or get better. And so that's kind of like planting the seeds. PRP, which I'm sure you all have heard of, is platelet-rich plasma. PRP, people hear about that a lot. Our blood has growth factors, and those growth factors are kind of like fertilizer. And the platelets, which are those things that when you cut yourself, you form a scab, they stop the bleeding so you don't bleed to death. But platelets form that scab, then they release growth factors, which helps the area heal. The cells in the area gives them fertilizer to help them heal. It also makes other cells come in, and blood vessels come into the area. So when we put the cells in, we almost always put the PRP, which is kind of like putting fertilizer on your garden. But then, you can't expect a garden, once you do all that, to really, like I was just in my garden, you have to prune, you have to support, you have to protect, you have to guide those plants, right? Well, it's the same thing. That's where the therapists, I love them. You guys are all amazing. You guys are the ones who guide them, protect them, support them, and stress them a little bit over time too. You need a little stress, not too much, to get stronger. Just like plants need a little pruning, etc., and they get stronger and they produce more fruit. And the harvest is always going to be bigger, or people are going to reach more goals if they have someone guiding them through the program. And that's why we like to call our V-Motion Fit people. They are all medical, like they're either doctors of physical therapy, ATCs, PTAs, but they all also have a CSCS, Certified Strength and Conditioning Specialist, or higher, and they all have a nutrition certification, and they all are certified in laser therapy, healing laser therapy. So we will also use healing laser, which is kind of like the sunlight. You can get a garden to grow in the shade, but it's going to grow better in the sunlight. And so there's different types of lasers that help the body heal as well. So we that's just a small amount of what we do, but I like the gardening analogy because I like to garden, but also because it makes sense that biology is biology, and we're kind of doing the same thing that you would do in a garden. We're just doing it with a human.
So sticking with your gardening analogy, which I think is beautiful, by the way, what are the insects and fungus and other things that can attack the process?
Absolutely. Those are like viruses and bacteria and also inflammatory cells. A great example of that is we have these cells called macrophages in our body. Now, macrophages are like, they can go in and they clean, like when you have an injury, they go in, it's an acute injury, like meaning it just happened, within days to a few weeks. Those macrophages, they go in and they clean up the area. They eat up all the dead tissue that got damaged, and they kind of almost somewhat like, it's like the rake going in there and raking away all the sticks and the leaves and everything and getting the garden ready. So they can do that. But if they stay in that stage, that's an inflammatory macrophage, okay? It's called an M1 macrophage. And it's the same cell, but it can be M1 or M2. And so when it's in the M1 phase, it's eating stuff up. But if it stays in that M1 phase, it's going to keep eating stuff up. You don't want to do that forever, right? You want it to switch over. You want the environment to switch over to an M2 macrophage or a less inflamed macrophage to help with healing now. So you want to clean up first, then you want to heal. So even the same cells, the same chemicals in our body, depending on how much there is or what the environment is, it can help or hurt. It's just like you need some calcium for the tomatoes not to get rotted on the end. But if you put too much calcium, it's going to kill them. You can't put, so it's the salt. So it's way more complicated than a garden when you really start getting into it. And the more we know, the more we realize we don't know. And that's why I love using cells, because cells know what to do. In my mind, God gave those cells the ability to know what to do. And so they know what to do. I do not know exactly how, none of us know exactly how all those cells work. That's why it's so difficult to say, oh, we're going to take this chemical and this chemical and this drug and that and mix them all together and make it work as good as how your body heals yourself. It's very difficult to do. We're not, that's why there's no magic pill, no magic one compound yet. Cell therapy is so impressive. It blows me away how amazing our cells help ourselves. It's amazing.
What would you say is the biggest breakthrough when it comes to regenerative medicine that you've seen?
I traveled over to Dubai before all this conflict back in, when was I there? I think February. And there were doctors from all over the world there who were doing regenerative medicine. And I was asked to speak on the bear surgery, actually, and trying to, repair knees and not replace them. But there's things going on like using animal cells. And I'm not saying this is the biggest breakthrough yet, but I'm just saying there's so much stuff out there that is on the horizon. I do think, in my mind, the biggest breakthrough in regenerative medicine is Dr. Hernigo himself. I think his research is by far, he's the godfather. So I'm going to say Dr. Hernigo, but I am also going to say that in the United States, we're not allowed to use other people's cells. We're not allowed to use donated stem cells like from umbilical cord or placenta that's going to get thrown out anyway. I have no problem using that. They're younger cells. Theoretically, they work better, but no one's proven that yet. Even though it sounds like they should work better, no one's proven that. And even though your body doesn't really have a reaction to them, like a rejection, over time, your body eventually realizes they're not your own cells and does eat them and get rid of them. Whereas if you use your own cells, like we do, your body's not going to reject them or get rid of them or eat them up at some point. They might, as Dr. Centeno says, stay in play. So now getting back to the animal cells, if you go far enough back in the maturity of a cell, a human cell and an animal cell very early on look very similar. So there's ways to kind of trick those cells into want to become a liver cell or a kidney cell or whatever, stem cell. And then there's doctors from Asia and all over the place who are doing this stuff. And then there was some debate whether you inject the liver ones into the liver or you just inject them. If you just inject them into the body, since they're liver stem cells, they will home to the liver and help that liver heal itself. And I saw examples of people who had cirrhosis of the liver. Their liver looked like it was destroyed. They used this therapy on them and their livers looked normal. So
Wow.
there's a lot of things that are just unbelievable out there that aren't quite in the US yet. And some of them are probably not, all they're made out to be, but there are definitely things that are out there that are even already being used now that are really, really, really amazing and groundbreaking that we haven't even seen really in the United States yet.
Well, speaking of, you mentioned things that aren't all what they seem. There's a lot of folks out there that are trying to DIY their own nutrition, you name it. They're trying to fix everything on their own. They've probably been in the healthcare system and maybe not got the answers they were hoping they would get. So they're seeking other alternative directions. And that's one of the reasons why we wanted to definitely have you on the show, was that, we wanted to, highlight some of the, people who are, doing it the right way. But there's also some areas that people need to look out for. If you were to kind of warn some people about things to be careful of, or some of the things you're seeing that maybe you don't 100% agree with yourself, can you highlight some of those?
Definitely. Well, first of all, the saying, if it sounds too good to be true, it's probably not true. Even though I'm excited about this regenerative medicine stuff, and people always, they're skeptical in the beginning, and I expect them to be, because it is amazing and it's very exciting. But I think one thing I would say is this: there's no way we can grow back a meniscus cartilage yet. Like, if someone's saying we're going to grow back your meniscus, your shock absorber cartilage, that's not being done anywhere. We're getting closer. There's scaffolds and things, but that's just not being done, or certainly there's no randomized controlled trials proving that can be done. Same thing actually with growing back cartilage on the end of the bone, meaning if someone has exposed bone, we're not good right now in just injecting cells in there and those cells automatically attaching to the bone and growing back cartilage and making you look like you were 18. Can some of that cartilage grow back? There probably is a little bit of evidence, definitely in animals, but even in humans, it's hard in humans because I'm a surgeon. I would love to go in, take pictures of the joint before we start, which is by the way of surgery, and then do what we need to do, and then go back in later, even if the person's feeling great, and take pictures. And we can't do that. So it's hard to prove in humans. MRIs are getting a little bit better. What probably happens in humans as far as the cartilage goes is that cartilage has cells in it, and they're called chondrocytes. Those are the cells but the white stuff isn't the cells. The white stuff is the matrix. People have taken glucosamine chondroitin sulfate. They've probably heard of glucosamine chondroitin sulfate as a supplement. Though that's the building blocks of your cartilage, that white stuff. So if you looked at the white stuff under a microscope, you'd see almost, it looks honeycomb, but the honeycombs are pretty far apart, and that's where the cells are. And then those cells produce a matrix, which is the actual structure of the cartilage. And so we probably, by putting PRP, fertilizer, or putting stem cells or other cells that help the stem cells, bone marrow in there, that stimulates those chondrocytes to produce more of the matrix. So there are a few MRI studies that show the cartilage has gotten thicker, and we've seen some of that anecdotally on our own, but there's no tremendously great studies that show we're going to totally grow back new cartilage. So when you see the Airplane magazine, or you see someone saying, oh, there's this treatment in Germany where cartilage grows back completely normal, that is completely not the case at this point. Now, can we get the bone to heal? And the bone, by the way, since the bone has millions of pressure-sensitive nerve fibers, the pain from arthritis comes from the bone. It doesn't come from the cartilage. So can we get the bone to heal? Yeah, that's easy to prove. You can see that on an MRI when that white signal goes away. And we can get that to heal pretty well, and we can prove that. And so that will oftentimes get rid of the pain. And then it's like, well, who cares what your x-ray looks like? Your pain's gone. You have full range of motion. You can do all the things you want to do, and you don't have metal, plastic, and cement in your knee. Are you good with that? And they're like, yeah, I'm great with that. So some of the claims that are like that, I think are the most common ones I see. Oh, can we grow cartilage back? Well, maybe a little, but not. I can't turn your 81-year-old knee into an 18-year-old knee. Now I can maybe make it feel a lot better and function way better and get the bone to heal, but we can't really, change that bone on bone to like totally normal again. That's completely false at this point. The other thing I would say is ask whoever is doing it, what are your results? And do you track your results? So we track our results in a national data bank registry called Data Biologics. People are invited to go look up Data Biologics, very reputable. There's about 200 regenerative medicine clinics in that registry, and we put all our results in there from all our patients. It's obviously confidential for the patient. And so you can see that regenerative medicine, pain goes down over time. Regenerative medicine, function goes up, pretty much in general and with all the clinics. But then you can compare yourself to others. So since we don't just do like a la carte, we won't just do a laser therapy only, or only a bone marrow shot, or only a PRP. I started out doing that a long time ago, but during COVID, when I couldn't do surgery, I put all those things together and they worked so well. I said, I'm going to keep doing this. And so if you look at our results compared to the rest of the people, the clinics in that registry, we have better results. But I think it's because we do programs. We don't just do, single treatment things, so to speak, a la carte, I like to call it. We don't do that. We do a program. And so ask them, what are your results? I'm so happy when people ask that, because we track our results. And a lot of places don't track their results, or they can't give you that. And are our results 100%? No, only death and taxes, right? But if we have, 85 to 95% of people getting 85 to 95% better, that's as good or better than surgery. So why not try it first? If it doesn't work, you're still probably going to be in better shape, as you would know, John, prehab, right? Getting the body in shape before you do a surgery. So we've had a few people that, they did this and they didn't get to where they wanted to be. But when they had their surgery, they did so much better. And it was so much easier because they had already done everything, all these other things ahead of time, and gotten their body in great shape and gotten those tissues into the best shape they could get them into.
Well, you mentioned the glucosamine with chondroitin. Do you recommend that to?
So it's a supplement, so it's not regulated by the FDA as much as other things. But yes, there are some supplements out there. I'm not going to necessarily say the names, but I tell people to, ask their pharmacist what they think a good, safe brand is. There's no evidence that glucosamine chondroitin sulfate is going to grow your cartilage back and make, bone on bone turn into a normal looking knee. But there is a little evidence that it helps protect the cartilage on the end of the bone. And frankly, and some people say it helps their pain a lot. I've run 7 marathons. I honestly think it helps me when I take it versus when I don't. And even yesterday, I had switched to a different brand because I ran out of the one that I normally use. And I switched back because I noticed that, because I like to run still a lot. And I definitely noticed a difference. So, it's anecdotal. I don't think there's super duper studies, but there's some studies that show it may protect the cartilage you have left. And it's a modest level of pain relief. It's not earth shattering, but I use it. But I would always say, ask your primary care and ask your pharmacist, because if you're diabetic, you might, or if you're allergic to shellfish, like you got to be careful. You got to ask your primary care, ask your pharmacist if they think it's good for you.
I'm assuming that your patients that do the best are people who come to you early enough. Is that an accurate statement?
That would be the ideal world, ideal statement. So yeah, no, people come. I wish more people came earlier, but they don't. So we get people who've been rejected by everybody, or told, so give me the worst person that you possibly can give me, and we are excited to take care of them because we know that they haven't ever gotten the level of care that they would get with us. But would it be easier to treat people proactively and ahead of time? Yes. And I have a great example of that. It just happened. So I give a lot of seminars and talks, and I was going on and giving the gardener analogy and all that stuff. And so this woman, she showed up. I actually had performed surgery on one of her knees before. She had a loose body in there, so that wasn't going to get better. And loose things floating around, you can put all the shots and stem cells. It's not going to get rid of those. You have to go in there arthroscopically and take those loose things out. That knee was doing, pretty good. Her other knee was bothering her more. She had some arthritis in both knees, not severe. She's like 63. But her MRIs from like last time I saw her, 2019, showed this stress or microfracturing, and she wasn't having a lot of pain right now. But we know from studies that people who have that stress or microfracturing just in one bone, like let's say it's the tibia or the femur, the thigh bone or the shin bone, 9 times more likely to go on to need a knee replacement than people who don't have those stress or microfractures, those soft spots. And if it's in 2 or more spots, it's 13 times more likely. So I went over all that with her. And if you read my book, at the end of the book, it talks about being proactive and preventive, and that's how we're really going to end the need for knee replacements. So she was very much into it, but she's like, gosh, I don't really have much pain. Should I even get checked out? And I was, and I said, well, I just gave her the facts, and she said, yeah, I should probably get checked out, because if I still have that, then maybe I do want to do something proactively. If I don't, my mind will be more at ease. Maybe they heal, because sometimes those will heal on their own. So she signed up, and a lot of it is out of pocket because of the insurance doesn't pay for you to get all that done in one day. They make you run through that cycle of insanity. So we get it all done in one day, which saves people a lot of time. And time is money, but time is also something you'll never get back. Time is just, once it's gone, it's gone. So forget the money part of it. You lose time, you lose time. And so anyway, she signed up. She goes home. Her husband tells her he doesn't agree, et cetera. Of course, he didn't come. That's why we always like to have the spouse or the loved one or partner come to any of these things. And she backed out. Now, I haven't had a chance to talk to her because I see her in church every week. So I'm going to talk to her, but like, it's so hard to get people to be proactive and preventive, even when they want to be. So she's not going to do it when, and I've seen lots of people like her who even are in pain, and they say, no, 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 no. And then they come back to you, then it is too late to do this. So it's so hard, but all you can do is give them the information and let them make their own decision. And at least they can make their own decision.
We have an audience that's pretty diverse all over the US really now. And, they may not be near where you're at, and they may want to know, well, how do I know if, I'm catching it early enough to really get the help I need, before that cartilage really breaks down and it's too late?
Sure. Well, there's a few things. One, yes, I'm going to peddle my book a little bit, just because like a lot of this information and a lot more is in here. And then there are some things you can do on your own that are in here that you can just scan the QR code. And there's like a 21-day plan that you can try to do on your own. And so there's free resources in there you can do on your own. And I think starting with educating yourself, like my book, but there's other books out there too. There's references in my book that people can read if they want to read. There's those studies that I talked about if people want to read that stuff on their own. So I think just educating themselves. And then as far as people being all over the place, we have people, I'm in upstate New York, near Syracuse, New York, but we get patients from all over New York State, all over the United States. We just had a gentleman, he's a farmer. He read my book. He's going to fly himself to our little airport in Skaneateles and see us next week because he doesn't want to have a knee replacement. So we get people from all over the place, Vancouver, a lot of people from Toronto, even Europe, Belgium. So one good thing that came out of COVID, I know there's a lot of bad things, but one good thing that came out of it is telemedicine, and even a lot of this telecommunication that we're doing even right now, right? So we're very, very good at telemedicine. If you need a procedure or you need to be evaluated, you still need to come see us in person, but people do that all the time. So one woman came from Belgium. She stayed with us for maybe 5 days. We did the procedure, et cetera, on her. Everything else after that was done by telemedicine in Belgium with her and her therapist, et cetera. She did great. She apparently did come back to the U.S. and visited Washington, D.C., but she didn't visit us because I wanted to follow up with her. But the point is, we don't need, you do need to see us, and we want to see you, and that's good care. But it doesn't, if you're remote, it's handled. We have a gentleman, like I said, right now the farthest person away is in Vancouver. But we have people from all over Maryland, all over the U.S.
Dr. Pietropaoli, how do people find your book?
Yep. If you just go to Amazon.com and type in Repair Not Replace, it's on Amazon. It's an Amazon #1 bestseller, so I'm very thankful for that. Or you go to my website, victoryinmotion.com. That works. Our phone number is 315-685-7544. And I'm also on pretty much every social media, either myself, Dr. Marc Pietropaoli, or Victory in Motion on Instagram, Facebook, YouTube, TikTok, LinkedIn. So if you look us up, Victory in Motion, I think it's Victory in Motion 1 on most of the social media, and Dr. Marc Pietropaoli on the other social media. You'll find us on that, victoryinmotion.com. And yeah, Amazon, type in repair, not replace.
Dr. Pietropaoli, thank you so much. You've really educated us today, and I really think your book's really going to help a lot of people who are really looking for other answers. Some of them are out there right now and they're just kind of geared up. They may be already on the books for surgery, and
who see us for sure.
Yeah.
I mean, it's worth getting an idea of what else is going on if you're a candidate. Some people still, they still need that knee replacement, but at least they know, and they know that was basically a good decision to make. But again, I would say, 82 to 95% of people probably we can either put off or avoid that replacement. And if you look at studies, 25 to 30% of knee replacements are considered unnecessary. I think it's higher, but that's what the studies show so far. So if you're thinking about it, it's worth getting another opinion at least and figuring out what the root cause is.
I have to ask, you focused on the knee today and your book and everything. Are you considering other joints?
I had it done on my elbow myself. That's in the book there. And so any joint works. The reason I concentrated on knee, and the reason why it's knee repair, not knee replacement, is because I did get upset with that chief resident and I wanted to prove him wrong. So, I was watching a knee replacement and I was like, I'm going to prove that guy wrong. I'm going to figure out how to repair knees and not replace them. So that is where that all comes from. And then in 2014, I really started to learn from Dr. Hernigo. I heard him speaking and fixing that underlying bone. And I started to say, we're going to repair your knee and not replace it, because I was still doing replacements. And so 2014 is when I really first started repairing knees and not replacing them. But it applies to shoulders, hips, ankles, elbows, tendons, muscles, ligaments. Our body's ability to heal itself is what we're trying to tap into. So we use it pretty much everywhere. I don't do injections in the neck or the back, but we do see a lot of people with neck and back pain. And if they do need either surgery or injections in their neck or back, I have people who are amazing colleagues who can help with that.
Well, our podcast really does focus on an older audience or aging audience, people who want to, but people in their 30s could benefit from, because this stuff happens earlier and earlier. We're finding that the whole idea of
Tommy John surgery, right? I mean, that's an epidemic in young people. And I just had someone, if their growth plate is still open, they don't want to do surgery and drill where the Tommy John ligament gets torn in a thrower. So we use a lot of bone marrow, which has stem cells and other cells that help the stem cells, and PRP together to help those heal in kids who have open growth plates. So yeah, kids as young as, I think the youngest person that we did the bone marrow on is maybe 13, and the oldest is in their 90s. So our bodies, especially when you're younger like that, you really have a great ability to heal yourself. Sometimes just PRP by itself in a teenager works amazing.
Yeah, we're trying to help people get more educated on things that are outside of what they might find, in a normal doctor's visit, or, just. And unfortunately, we live in a society that is very driven by profits and business, and that can take on a predatory aspect. And people get into healthcare because they care about people and want to do the right thing. And sometimes that gets twisted by the systems that they have to work in. And so I think we have nothing but amazing people in the healthcare system. I think sometimes the system itself has made their jobs so difficult that, in order to keep their job, they have to cut corners in ways that aren't in the best interest of the patient. And I really appreciate the system that you put together. It feels like you're definitely on the right path for, long-term joint health, because that's a deal breaker for, I can't tell you how many older adults that I got to see that, their lives came to an abrupt halt because, that their knees were bone on bone. They couldn't get up and walk anymore. They weren't safe anymore. It reduced their ability to have functional mobility or even healthy mobility. And it just started this, snowball into other, disorders. And, again, you can go back to chicken and egg, and I don't want to go down that rabbit hole, but the joint function, it impacts so much of people's lives and their quality of life. And so I really appreciate the work you're doing.
No, thank you so much. And just two little final points on what you said, because I think what you just said was very profound. Number one, almost every healthcare professional, not all, right, because there's good and bad of every field, but almost all of us go into it because we want to help people. There's no doubt about it, right? And when I was interviewing for medical school, I remember some advisors telling me, make sure you don't say when they ask you why you want to go into it that you want to help people. I was like, that doesn't make any sense. Why? Well, everybody says that. I said, well, that is why I want to go into it. But so I bucked that, and I was like, of course, I said why, and then I explained as well. But I get a lot of students who come through, and I always tell them, never be afraid or ashamed to say you went into it to help people. Now, on the opposite side of that, I never thought I was going to go, and I never thought I would go into business on my own. But I left this is a long time ago. I left the group, and I still had a traditional orthopedic surgery practice, but I've been in business on my own since 2001, and we don't get any training on that whatsoever, which I think is bad too, because you can't help people if you don't run a profitable business. You have to make a profit. You can't spend more than you bring in, because you can't stay in business. Then you can't help people. So that is the little thing that doctors and healthcare providers and staff members in medical offices, they have a hard time with. And we all still have a hard time with that. We didn't go into it for like to talk to people about money and all that stuff. But the bottom line is, if you don't make a profit, you can't stay in business. So you do want to be profitable. You want to be smart, and you should be very, very proud of being able to help people with any product that you can make a profit with, that you're actually helping people. There's no reason to not be proud of it and preach to the world about it. It's the opposite when you have something that you're trying to, scam somebody or whatever, and just make a profit. That's a whole different ball game. And you're right. Most medical providers, even the ones that are trapped in the system, like I was and you were at one point, it's not their fault. They don't want to be in the system like that. It's the system that's just destroyed a lot. And doctors and healthcare providers had a very high rate of suicide, et cetera. So I don't even want to get into that, but high rate of mental health issues. So it's tough.
Thank you again so much. We've really enjoyed talking with you. We've learned so much.
Well, vice versa. Thank you for having me on. I appreciate it. Thank you, your audience as well, all throughout the U.S. and the world.
Don't forget, find his book right now on Amazon.
Thank you. I appreciate it.
Thank you. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.